And we just want to welcome everybody. Please fill out the poll to sign in. We do have everybody on mute upon entrance just to reduce distraction and noise. But if you have a question, we have a team looking at the chat, so please pop in your question. And during the Q&A, we'll unmute everyone. Just for everyone's awareness, we're not doing AI notes. We are notes. We will be recording this session and posting it. So um, apologies for any inconvenience, but we're denying all the AI notes for now. Okay. But Jim, maybe, Chief, we're going to give everybody maybe another minute, you think? And then if Chauncey hops on, somebody can please let me know if I miss him. I don't see him on the screen, and I will unmute him. See, Rhiannon, we've been looking forward to this for weeks too, so we don't think you'll be disappointed. I think we could, Chief, when you're ready, we can get started, and I'm going to just check my emails to make sure no one's having difficulty accessing the link.
Sure thing. So welcome everyone. For all of you who are regular participants, welcome back. As you know, the New York State ORS team always puts on phenomenal learning sessions, and I can guarantee that you are not going to be disappointed today. So in light of that, I want to give a real special shout out to Lisa and Jim, who do so much in putting these together and always leaving us uplifted at the end in terms of the clear path forward. They are absolutely phenomenal individuals. And while I'm shouting out people, I want to do a special shout out to Sergeant Emmy Escoffier, who received from New York State Department of Health the Community Partnership Award up in Albany yesterday for her work in all that she has done to help reduce overdoses in New York City. I know Lisa is going to do the introduction of Dr. Loyd, and I just want to take 2 quick moments to say how much I am a fan of his. The work that he does, like so many of us in this field, which I've been a part of for 4 decades, he is passionate. It is a calling, and he is so focused on his mission. And I can't tell you how blessed I am to have him as a colleague. You are absolutely going to leave today after listening to Dr. Loyd speak with a renewed enthusiasm for the work that we all do. So welcome, everyone. We're glad you're here. And at this point, I'm going to hand it back to Lisa and Jim.
Jim, you're up. I'm going to end the poll here. Let's get to the next slide. Jim, you're on mute.
Sorry. Thanks, everybody, for being here today. Thanks, Chief, for the introduction. It's great to have you here. For you people who don't know Chief Tobin, she's joined New Jersey HIDA as an advisor after 41 wonderful years with NYPD. So thanks, Chief. We appreciate it. Lisa and I are just going to give you a quick overview of the New York ORS before we get into our speaker, Dr. Loyd. The ORS program itself is a collaboration between the CDC and ONDCP through the HIDA programs. And it covers all 50 states, Puerto Rico, and the Virgin Islands. There are 61 two-person teams that are part of that comprise the ORS. And one is a public health analyst, and the other side is the drug intelligence officer, which I am. So our focus is to reduce overdoses. It's pretty simple. We work on proven strategies, share them with our partners on the federal, state, local, and tribal levels. A couple years ago, when Lisa joined the program, we did a comprehensive overview of what was going on in New York State, and we came up with 6 buckets that we thought we could make an impact in, and they are data, post-overdose response, primary prevention, overdose fatality reviews, expanded access to naloxone, and partnership building. And that's part of what the reason for this call is, just to bring all of our partners together, get everybody to know everybody. It's great when you start connecting names with faces. And if you need something, if law enforcement needs something from public health or education, we hope we can help make those connections. And with that, I'll kick it over to Lisa.
Thanks, Jim. Yes. Welcome, everyone. Just a quick overview, a reminder about these sessions. As you've all heard, we have a new registration site. We recognize some of you have had some issues registering. We're going to work on resolving that. But in the future, we plan to post all of our quarterly sessions on this site. And in the off periods that we will have, there's a link to join our listserv so that no matter what, you can sign up and you'll get notifications about future sessions. So we plan to have quarterly sessions as well as ad hoc special guest speakers and other topics of interest. And we appreciate all the feedback that we've gotten from all of you on topics of interest, and know that we look at that and we're going to be compiling that as we look into 2026 and what we will hopefully schedule for learning sessions. So with that said, the reason why everybody's excited to be here is I want to introduce Dr. Stephen Loyd. So Dr. Loyd, he is an amazing friend of the ORS, and he is, we all know him, or a lot of you are going to know him as being the inspiration behind Michael Keaton's character in the Hulu series Dopesick. But he is so much more, and you're going to see that you're going to be impressed by not just his story, but his expertise and what he brings to the table. And most importantly, what he brings to the table is every piece of his heart, and you will feel that and sense that. And the compassion he brings to people struggling with substance use disorder, and just the work around this is that will resonate with you and touch you. So with that, Dr. Loyd, he's currently also the Chief Medical Officer for Cedar Recovery in Tennessee and the Chair of Tennessee Opioid Abatement Council. And a director of for the Office of Drug Control Policy for West Virginia. So he's got a big bio, so it's posted on our website. But Dr. Loyd, I'm going to stop the share here, but I'm going to allow our HIDA director, Chauncey Parker, who's also here, to say a few words. And Chauncey, give me just a second, and I'm going to unmute you. So you can unmute yourself now.
And
Thank
so
you,
for
I
all
just
of
want
you, you should know that it is because of Chauncey Parker we're able to convene in this large gathering. So a big thank you to the director of the New York, New Jersey HIDA.
Well, thank you, Chief Tobin. And it's because of you that this whole thing started 15 years ago called RxStat that is now a national partnership of public health and public safety. So I just want to welcome you all. This is all about the power of partnership and that we have to do this work together. We have to be focused on our goal, which is to reduce overdoses and save lives. Lisa, you and Jim are remarkable. Whatever job description you started your job with is unrecognizable to what you have done in your role. And so we just, for Chief Tobin, for me, for the whole team, we just follow you just tell us what to do and we'll support it. And Dr. Loyd, we know each other well. You're an inspiration. You, as Lisa said, you lead with your heart. You're clear-eyed, and you really have the lantern to tell us as a region and as a country the best path forward to accomplish this very, very, complicated but not insurmountable challenge. So it's just a great honor to work with you, Dr. Loyd, and be able to support you in any way you can. And to the whole team, thank you for joining, because this is all of us together. So back to you, Lisa.
Thank you, Chauncey. Yeah, he's the other amazing inspiration behind the work that we do, and not just in the New York ORS, but the national ORS program. So thank you, Chauncey. We really value your leadership. Dr. Loyd, it's all yours.
Thanks, Lisa. Lisa, can you hear me?
Yes.
Make sure I get so far into talk sometimes I realize I've got my mute button on, and I'm the old man standing out in the yard yelling at the sky. So it's so good to be here, and it's really kind of an awesome world I get to live in. How in the world do I get to know people as well as I know them that are in New York? And I'm a Southern boy. I'm coming to you today from Southwest Virginia. Little town called Abington, which is actually a really beautiful place. But Chauncey, thank you for everything you allowed me to be able to do. And Lisa and Jim have just been great to me. And meeting Chief Tobin is one of the red letter days in my life. I'm a huge Terry Tobin fan. But what we're all here together today to talk about is, how do we reach hurting people? And hurting people aren't blue or red, and they aren't from this side of the tracks or that side of the tracks. They're just hurting people. And it's so hard for me sometimes in some of the circles I run in, but I keep my focus on that. I try not to get distracted by other issues, other things that take away from us providing people who are struggling with the things that they need and the tools that they need to find recovery. I wake up every morning and I have one goal, and that goal is to help as many people find recovery today as I can. And I really don't have any other goals. And I told Lisa not long ago, I did a radio interview where I defended Rush Limbaugh and Hunter Biden in the same interview. And that happened because both of those gentlemen, in one passed obviously, but suffer with the disease of addiction. And it is not okay to stigmatize that, for political gain. And I just don't believe that. And so I'm a one issue guy, and that's my issue. And I'm grateful to be here. If I get run out of where I am, because I had to get me a space, I'll adapt and overcome on the run. So, but it shouldn't be it shouldn't happen before the end. I will tell you, the last time I was in the city, we were in one of the big, beautiful buildings in Lower Manhattan that Lisa had to help me navigate around. And one of the first people who spoke that day was talking about another person in the meeting, and they said, it's good to hear a nice, thick New York City accent. Well, I'm not going to bring you any of that today. I'm going to bring you a East Tennessee accent that will never be confused with New York City. But the characteristics surrounding the topic are the same here as they are in New York, as they are in California, as they are really in any part of the world. And so with that, I will get started. Just a brief. I think the most interesting thing about me is probably the Dopesick thing, and I want to get started there after I figure out how to share my screen. I told Lisa I never get upset or worried about how this is going to go because I know it'll go the way it needs to. I get scared to death of the technology. So let me make sure that I can get my slide here up and begin. And I promise I'll finish on time. Okay. Lisa, can you all see it? Okay. And let me get rid of the closed caption. Oh, I'm so impressed. I know how to get rid of closed caption now. I'm so happy. All right. So I'm an internal medicine physician by training, born and raised in Northeast Tennessee in rural Appalachia, a little town called Jonesboro. I highly recommend visiting it. It's a place I spent most of my life trying to get out of, and I've spent the past few years trying to get back to. So kind of that kind of thing. But I grew up in Northeast Tennessee. I went to medical school, did my residency in East Tennessee, and I'm trained in internal medicine. And I really had addiction nowhere on my radar until it landed in my living room, in my bedroom. Me. And so I'll tell you about that, but I want to tell you about the slide you have here because it gets into my talk and the reason that we're all together, because Chauncey and Jim and Chief all alluded to the partnership between all of the different agencies and what we're trying to accomplish. And looking at my career, my most valuable partnership that I've formed through the years has been with law enforcement and the criminal justice system. And I never had that on my radar. Most of that today, I've got on my Nash hat. And if you're wondering why I'm wearing a hat, I'm bald. So there you go. You've seen it. But I always wear a hat. And most of the time I have a Department of Corrections hat on from somewhere, which is a strange thing for a doctor to be wearing. But the reason I do that is because of the partnerships that I have with the folks working in law enforcement and criminal justice, and because we have the leverage in these places to help people find recovery. And I'm going to explain to you why that's so important, because in the midst of addiction, people lose access to the frontal lobe of their brain. And the frontal lobe of your brain is only important if you care anything at all about insight or judgment. If you don't care about those two things, it doesn't matter. So when you lose insight and judgment and you're struggling with all these addiction things going on in your life, and your life is going really downhill fast, you've been incarcerated, you've lost your wife, you've lost your kids, you've lost about everything that you have, you can't see that. You can't see that you have a treatable disease. And the only predictor of long-term outcomes that are positive in addiction treatment is time engaged in the program. And so if you look at the only place that we have leverage to keep people engaged in the program until their brains can start to recovery, it's really criminal justice, unless somebody has a professional license of some sort, like I did with a medical license. And I'll explain to you the importance of that here in a second. So these partnerships are so valuable. Every time I'm around, Chief and Chauncey and Jim and Lisa, I learn stuff all the time that I can use for my patients. And hopefully they learn a little bit from me that we can use to try to help the folks that we're trying to target. So, I'm a trained internal medicine physician. The addiction medicine that I know and practice and have for the last 15 years, I'm completely self-taught. Back when I was coming through, there were very few training programs in addiction medicine. It's gotten a lot better. But frankly, guys, I'm 58 years old and I'm too old to go back to school. So I'm kind of like Abraham Lincoln. He was a self-taught lawyer. I'm a self-taught addiction medicine guy. But I will promise you this. I probably need some hobbies. This is what I do. It's what I do for my job. It's what I do in my relaxing times when I'm trying to unwind in the evenings. I promise you this is what I'm reading. And I'm constantly trying to learn pathways to help folks find recovery, because that is the absolute most important thing that we will do to help them. So several years ago, I was working for the state of Tennessee. I was the first drug czar for the state of Tennessee. And my phone rang one afternoon. It was this lady named Beth Macy. And I didn't know Beth. It turns out she's a writer. She's an investigative reporter from Roanoke, Virginia, but she has been a New York Times best-selling author 2 times already. And she's working on this book called Dopesick. And Dopesick is about the story of the Sacklers and Purdue Pharma's marketing strategy that unleashed the OxyContin epidemic on the United States. And really, we're still recovering from it now, and will be probably for the next 20 to 30 years. And so Beth is writing this book, basically based in Southwest Virginia, and she's at the end of it, and she had been writing it for about 2 years at the time I met her, and she was almost done with it. And the reason that she called me is she said she was asking around because everything was doom and gloom, right? Everybody died in the end, and there were no happy stories, and that's all she was seeing. And she goes, "Is anybody out there offering any hope?" And she said, "Steve, several people gave me your name." Well, that made me smile for one thing, because I'm full of hope. I'm optimistic. I think with the brain power and the cooperation that we have going on in this country, particularly with things like HIDA, I think that we're going to come out on the other end of this. I think Chief would agree with me that too many people will have died, and I think we all agree with that. But I do think we'll come out on the other end, and so I am optimistic, and so it leads me into the Hulu series Dopesick. So Beth and I get to be friends. She uses one of my stories to end her book. It was a New York Times bestseller again, the third time she was a New York Times bestseller. It sold about 500,000 copies, and so we became friends, did some talks together. And then about 2 years after its release, she called me up one day. She goes, "Hey, Steve," she said, "they want to make my book into a Hulu series." And I said, "Oh, Beth, that's great. What's Hulu?" And and she said, "Well, it's a streaming service." I said, "Well, you're going to have to do better than that." She said, "Well, it's like Netflix." Well, I was paying for 3 Netflix accounts at the time, so I knew what Netflix was. And she said, we're gonna take the book and we're gonna fictionalize it and rotate the stories around a fictional doctor based in rural West Virginia, and I'm from Tennessee, but rural West Virginia, and the doctor is going to get addicted to the drugs that he's prescribing for his patients. And she said, "We would like to have you help us in writing this." And I have no experience with writing whatsoever, but I loved Beth, and I said, "Of course we'll do that." And so we get together in March and in April of the year 2020, which was the pandemic year. It was the only month Tennessee was closed. And the writers and producers are all in Hollywood, and Beth is in her home in Roanoke, and I'm in my home in Nashville. And we're going through these scenarios, with the writers, and every scenario that this doctor goes through, that's not how it would work in a hospital, and I'd have to tell them why. And finally, our producer, Danny Strong, said, "Steve, why don't we just use your stories, right? We know those happened." And guys, 2 things went through my mind in really rapid succession. The first thing was, we're not going to use my stories because I'm going to take those to my grave, right? I don't want the whole world seeing those. And literally that lasted for about 10 seconds. And this is how I'll launch into my talk. I started thinking about this. What if you had a disease you never saw anybody get better from? What's that like? And we all have had people die in our lives, and we've heard of people, getting diagnosed with brain cancer, glioblastoma, or pancreatic cancer, and we all know that they're going to die. They're going to die in 6 months to a year. It is a death sentence. And so what's it like to have a disease like that where there's no hope? And I thought about that, and I thought, that's not going to happen. And I said, absolutely, we'll do that. And so if you watch the series, everything from episode 3 on really happened in my life. Those are real stories. The only 2 things that I didn't do, I didn't buy a school bus. So if you watch the series, the Michael Keaton character who plays me buys a school bus to take people to treatment. And I can assure you, as many people as I've taken to treatment in the last 21 years, I should have bought a school bus. And then the other thing I haven't done is I haven't relapsed. I've been in recovery about 21 years and 5 months. And guys, that has almost nothing to do with me and almost everything to do with the support system that I have around me. And the prevailing theme of this talk today and my time with you is the opposite of addiction is not recovery. The opposite of addiction is community and relationship. And we have multiple tools to help with that, but that is the basis. Community and relationship. And so I told you that whenever we were doing this, we were doing the writing, I had no idea who they were going to cast. I didn't even know how much money that they had. So, that's going to determine who you're going to be able to afford. And so when the series came out and they had Michael Keaton in my role, I thought, well, that's not bad. I tell people before he got my role, he was a hack, and I shot his ass to stardom, which is obviously not true. But something that Keaton talks about, publicly is he got interested in the role because he lost a nephew to fentanyl addiction. No one is immune. And I thought he did a great job with the role. He's probably a little better looking than I am, but I really thought he did a great job with it. It's 7 episodes long. It is accurate. It is what people go through, and I'm not telling you this to get you to watch it because I made money off of it. I did not make money off of it. I do not receive royalties. The show won 2 Emmys. Keaton won 1 for Best Actor. Now, I will tell you, if I do have a resentment, it's that because I didn't win crap. And I had to live it, and he didn't, and he gets the Emmy, and I don't. So I'm salty about that. And the other one it won was for cinematography. We got beat out for Best Show by something called The White Lotus, which I've never heard of, but apparently it's pretty good as well. So when you see the picture you have in front of you, I take Tennessee with me wherever I go. I'm a proud Tennessean, and I am a Southern boy. And so one of our famous Tennesseans is the author Alex Haley. And Alex Haley wrote a book called Roots in the 1970s that was the historical fiction story of his family's enslavement in the United States after being captured in Africa and dropped off in the United States in the middle leg of the in the Third Passage. And so Haley's family was enslaved in West Tennessee. Alex spent most of his life in East Tennessee in a little town called Norris, just above Knoxville. And Alex talks about a turtle on a fence post. And so I stole it from him because he's a Tennessean. There's one thing you know when you look at this picture and having no background, you know for sure that turtle didn't get there by itself. That turtle did not shimmy up that fence post. When you see somebody like me in recovery, or those of you on this line who happen to be in recovery, because with the numbers, I know there's at least a few. When you see somebody in recovery, they did not get there by themselves. They are a turtle on a fence post. They have a system around them that supports them in their recovery, that allows them to live their life in recovery. And that's our goal, guys. It's what we're trying to build. You know, when I first met Chauncey through Lisa and Jim, and I first met Chief through Lisa and Jim, and I got to sit in on some of the stuff there in the city, I was blown away at the teamwork that goes around gun violence in the city. It's one of the most amazing things I've ever seen. And I swear these professional men and women from all different areas of our city did it in about 45 minutes. I'm still blown away by it. When you see that level of teamwork around trying to solve this issue, that's the kind of effort that it takes. And the people that are helped by that, you know, that's the turtle on the fence post, right? That's the system supporting the end goal. So our end goal is exactly what you see in front of us. All right. So the number you see there is 107,622. And if you were a live audience, I'd ask you what that is, and there'd be responses. And so this number is the number of people who died of drug overdoses in the year 2020. Now, obviously, I've got updated data, but I use this for a couple of reasons. One is I want you to know one of the 107,622. And so in the course of my talk, you're going to meet one of these. And the other is to show you the number. You know, one of the dangers when you get a number that gets so big is it becomes that just a number or a statistic. There was a mass murderer from the 20th century who I will not honor by saying his name, but he said 1 death is a tragedy and 1 million deaths are a statistic. And I think we have to be very careful with that. As I watched those men and women of the NYPD and everywhere else that was represented in the room that day in New York, I was amazed at the level of compassion that they had for the people who were victims, and for a lot of times the people who were out there in the system that needed help that they couldn't get because of the way the system is set up. Guys, this is a personal thing. Behind every one of those 107,622 is somebody's mom, dad, brother, sister, son, daughter, aunt, uncle, grandma, grandpa, somewhere in there. And so that number, just to give you some reference, that number is equivalent to a 747 airplane fully loaded, crashing and burning, killing everybody on board every 36 hours around the clock for a year. And I dare say if that was happening, none of us would fly. Yet it lives over here by itself. People almost never talk about it. And whenever you lose somebody in your family, it rips the fabric of your family apart. And the stigma is such that you can't tell anybody. If your kid had cancer or your kid had a debilitating disease that took their life, there would be an outpouring of sympathy and casseroles in the South being delivered from every possible church group, right? But when it's addiction, that doesn't exist. When it's addiction, we will go into our friend groups and the community organizations that we belong to, and we won't bring it up, and we'll live in silence. And guys, we have to break that. The single biggest thing that we face in our battle against substance use disorders is not lack of funding for housing or treatment programs. All those things are important. It's actually the stigma and the way that we approach people with addiction, because we look at it as somehow it's a moral failure or a moral hole. that they should be able to do something about if they would just go to church more or walk and left little old ladies across the street. And I'm not saying those two things are bad. They're not. But that is not going to solve our issues with addiction. This is probably the only slide. I think I only have one other slide that has words on it. And I'm not denigrating our system of care now. Our system of care now has a lot of dedicated people that have worked very hard. But the truth is it's broken. And it's not going to be fixed anytime soon. And that we now have money in the form of opiate abatement dollars to start to fix that system, yet we're spending it on things that aren't going to get us where we need to be. And so every system is designed perfectly to get the results that it gets. And our system of care in the United States is designed to give us 107,622 in the year 2020. And you're going to meet one of those momentarily. So the first thing I want to do, and this may be repeat for some of you all and maybe sophomoric, if it is, I apologize, but I think it's important for us to get on the same page. You need to know the difference between dependence and addiction, okay? So dependence is easy. Dependence means when I stop doing something, I stop taking something, I get sick. That's about as easy as I can make it. Does it mean you're addicted? No. It means you're dependent. It means that whenever you stop taking it, you're going to go through a withdrawal syndrome that's symptomatic. So you'll have symptoms. And after a period of time, based on the half-life of the drug, which means how long the drug stays in your body, that's how long your symptoms will last. And then you'll be done with it, right? And not all drugs cause dependence. So I'll give you some common ones. Methamphetamine. Methamphetamine and stimulants. We've got a rise of cocaine and meth use in the United States, and I'm sure we do in the city itself. And people, when they stop taking cocaine or they stop using methamphetamine, they don't get sick. Now, they're going to feel down, but they're not sick. Those drugs do not lead to a physiologic dependence, okay? Now, drugs that do lead to a physiologic dependence. Number one, alcohol. If you drink alcohol for a long enough period of time and you develop an alcohol use disorder and you're physiologic dependent on it, you can't just cold turkey quit. You can die from something called delirium tremens, all right? And I think most people know that. Benzodiazepines, Valium, Xanax, Klonopin, Librium, those type of drugs produce a physiologic dependence. And again, the withdrawal from those drugs are potentially fatal as well. Opioid, prescription pain medication, OxyContin, Percocet, Lortab, Vicodin, right? All of those drugs, fentanyl, all cause a physiologic dependence, meaning when you stop taking them after taking them for a period of time, you get sick, right? That is dependence. What is the difference between dependence and addiction? Addiction is more behavioral. Now, there's a bunch of different tools out there that you can use to evaluate somebody for having addiction. Probably the most common one is the Diagnostics and Statistics Manual, version 5, that gives you the DSM-5 criteria for addiction. And if your patients meet so many of these criteria, then you can diagnose addiction. And those things are all well and good, and I don't need any of them, all right? All I do is I look in my patient who I'm evaluating, I look for the continued use despite consequences. When I can find the continued use of a substance or a process like gambling, internet pornography, computer, gaming, right? When I can find evidence of continued use despite consequences, then I can make a diagnosis of addiction, and I'm going to be right about 80% of the time. All right. And the hallmark of addiction is the phenomena of cravings. And guys, you have to understand cravings. Okay. Two big things about cravings. Number one, they're lifelong. I've been in recovery for about 21 and a half years. I can assure you I still have cravings. I also have 21 and a half years experience in being able to deal with those cravings without using, right? Support system, things I do. I'm an exercise fiend. I watch what I eat. I take really good care of myself. I get the proper amount of sleep. I have learned how to deal with cravings over time, and I've got this support network that I can reach out to at any time. So the first thing about cravings are they're lifelong. And here's the second thing, and it's the most tricky. Cravings happen in as little as 33 milliseconds. How long is that? It's the time it takes you to blink your eye. Now, I want you to think about that for a second. You blink your eye is unconscious. It's so quick that your brain is not even conscious that you're blinking. So somebody who has a craving for their drug, the craving actually is on them before they're even conscious of having the craving. And therein lies the difficulty. How do you defend yourself against something you're not even aware is happening? I can't tell you how many people I've interviewed after a relapse, and they said, Dr. Loyd, I have no idea what was happening. I was in this situation, and the next thing I know, I was using. I believe that. I know that. And so, guys, it takes a long time to help people, give people the tools that they need to be able to deal with those cravings that happen so quickly. and cravings are why people relapse. I'm going to talk about medication-assisted treatment in this talk. 3 drugs: buprenorphine, that you all know as Suboxone, Sublocade, the injectable Brixadi, methadone, and naltrexone, sold under the trade name of Vivitrol. Why does Steve Loyd love medication so much? Medication quells cravings. Doesn't get people into recovery. It quells cravings and saves lives. If we can keep people away from relapse, get the needle out of their arm, now we can hold them in treatment programs, and a lot of times using the leverage that law enforcement and the judiciary have behind it, then we can help them find recovery and get at those underlying drivers of addiction. I love medication. They have a 70% mortality benefit. What does that mean? That means that 70% of the people who are taking them will live when they would have otherwise died. Name me another drug out there that has a 70% mortality benefit. I'm going to save you some time. If you don't count insulin, you can't, right? And so we have highly effective drugs that hold cravings at bay, but they do not get people into recovery. There's so many more things that are needed. We have to get at the underlying drivers. Most of the time, it is underlying childhood trauma, physical, sexual, emotional abuse, and untreated behavioral disorders, depression, anxiety, post-traumatic stress disorder, right? Those top things. Those are the underlying drivers of addiction. So can you be dependent and not addicted? Yes. And I've got Chief Tobin right in the middle of my screen. So everything that I'm going to put patients through today is going to be Chief Terry Tobin. So Chief has to have her gallbladder out. And they put her on pain medication after her surgery because she needs pain medication because they cut her open and took an organ out from underneath her liver. And so she's been taking that medication for 14 days, and now she's off of it. And when she comes off of it, she's going to get Dopesick. She's going to have some anxiety. She's going to have some empty feeling in her stomach. She's going to have a little goose flesh. She may even have trouble sleeping for a couple of nights. Does that mean Chief Tobin is addicted? Nope. That means Chief Tobin is dependent. And that dependence will wear off after a couple of days, and Chief Tobin will go about her life, right? Now, if 2 months or a month down the road, Chief Tobin developed cravings for that drug, right, and starts to go out and seek that drug, now we're talking about a different thing, right? We're talking about continued use despite consequence, and the hallmark is cravings. Not everybody develops cravings. So addiction is the compulsive use and continued use despite consequence, hallmark cravings. Without cravings, we have no addiction. In Chief Tobin's case, post-operatively, she was simply dependent. That happens all the time. Can you be addicted and not dependent? Absolutely. Methamphetamine and cocaine, right? I've already told you they don't cause dependence. Do you guys ever see continued use of methamphetamine and cocaine despite adverse consequences? Every day. So that's the difference between dependence and addiction, and they're important to deal with. Why? About 10 years ago, I got this young man who was on methadone. He'd been in a methadone clinic for about 5 years. He came to see me, and I'm taking his history. It turns out that he had hurt his knee playing college baseball. He had complications from his ACL repair, and he had to be on pain medication prolonged. He had no risk factors for addiction. He had no family history of it. He had no childhood trauma, and he had no past history of addiction issues himself. Yet when he started to withdraw from the pain medication that he had been on for so long, his orthopedic surgeon said, "Oop, you're addicted," and sent him to a methadone clinic who did no further evaluation of why he was in withdrawals and put him straight on methadone. I love methadone. He did not need methadone. He was simply dependent. He needed treatment through the dependence process so that he would no longer need medication. And I had him off of everything in about 6 months, which is a real shame because he had been going to a methadone clinic for 5 years because somebody didn't understand the difference between dependence and addiction. And that's why those two things are important. All right, so we're going to get into this. I love this stuff. It is so good. So we all know addiction as a biopsychosocial model. And guys, when I was learning about this, I wanted to be able to come up with a talk that I could teach about addiction in the county jail or at Vanderbilt's medical school. And I didn't want to change my slide deck, okay? I want to use the same one for both people, right? Because it's been my experience that most of the people in jail or prison were just as smart as the kids at Vanderbilt's medical school. Okay. They just really are. And so I came up with the idea of using a slot machine because addiction is taught using the biopsychosocial model. Okay. And to me, that sounds like psychobabble. And I understand a slot machine much better. So a slot machine is when the 3 sevens come down on the pay line. That's when the money comes out. Okay. Lisa, can you see my arrow? Is my okay? And the thing I love about the new Max, I can make the arrow as big as I want, and this thing is huge. My kids make fun of me for it all the time. They said, "Dad, your computer will do so much more than that," but I'm impressed with the big arrow. All right, so when you're looking at a slot machine, the 3 sevens are the biopsychosocial model. If you want to know if somebody's at risk of addiction and you're about ready to prescribe them a pain pill and you want to know, is this person at risk, use my slot machine. The first 7 is the bio part. What is your family history? 60% of addiction is genetic, not 100%. So if I want to know if Chief Tobin, my patient who's in front of me, who's shooting, who I'm getting ready to write a pain pill because she's broken her leg, if I want to know if she's at risk of addiction, I simply use my slot machine. I explore Chief Tobin's family history. Yeah, Steve, when I was growing up, my dad had an issue with alcohol that actually led to him and my mom getting divorced later on in life. All right. So I know for a fact her dad wasn't just a casual drinker because he had continued use despite consequences. The most important thing to most people are their family, their significant other, or their kids. If you continued to drink to the point you lost your family, then that's continued use despite consequences and not a casual drinker. So Chief Tobin's first 7 is on the pay line. Second 7 is the psycho part of the biopsychosocial model. What kind of household were we raised in? Now, I don't want anybody on this call, and I don't know how many we got on here because I can't see, but none of us came out of normal households because they don't exist, okay? But some of us come out of places that are worse than others. Physical, sexual, emotional abuse, big T traumas, right? And so I want to get to that. I need to know Chief Tobin's risk for that. Guys, I don't have to dig very hard. If I've got a good relationship with my patient, Chief, tell me what it was like growing up in your house. You know, you told me your dad drank and the point it cost him his marriage. You know, what did you see growing up in that house? Well, Steve, sometimes Daddy would come home and he would have drank his paycheck, and him and Mom would get in arguments, and they'd do it in front of me and my little brother. Chief, did they ever get physical? Yeah. You know, I saw on multiple occasions, you know, Dad would lose it because he would be drunk and he would beat Mom up. All right, guys, that's emotional abuse. Kids were not made, we're not primed to watch the people, their gods, skin God. Don't be under any illusion. When you're a kid, God is Mom and Dad, and they weren't conditioned. They weren't brought into this world to see that. That's emotional abuse. Well, Chief, tell me about as time went on. Well, Mom and Dad got divorced. I lived with Mom, and she had boyfriends coming in and out of her life, you know, until I went away to college. Chief, in that time that she had these folks coming in and out of her life, did anything ever happen with any of them and you that you now looking back on know what it needed to be? I don't have to get any more specific than that. People know what you're talking about. Yes, Steve, on occasion that did happen. I don't need to know anymore. Number one, I don't want to crack Chief open, right? Because Chief's going to have to go back out in that world here in just a few minutes anyway. And number two, I am not a specialist in sexual trauma. I need help with that. But I've identified it as a risk, right? And so I know I've got Chief Tobin sitting in front of me right now. She's got a family history. She's got a history of sexual and emotional trauma. All she's waiting on is that third 7. And the third 7 is the social component of the biopsychosocial model. What's widely available and socially acceptable? What's the most widely available, socially acceptable thing people have trouble with? By far, it's alcohol, right? I'm 21 years old. I got an ID. They sell it on every street corner in the city and basically anywhere else. And so that's widely available and socially acceptable. How in the world did opioids become widely available and socially acceptable? And Dopesick does a really good job of showing this. But back in the late 1980s and early 1990s, pain societies popped up around the United States. They started marketing pain medication that's long-acting as being less addictive than short-acting pain medication. And we're doing a bad job of treating chronic pain because we're too scared of opioids, and they're really safer than we think they are because we've got this new one that's long-acting that won't cause addiction, less than 1% chance. And that's how they marketed the drug OxyContin. Now, keep in mind, nothing that I just told you is supported by any medical literature, yet that made it into the package insert by the FDA. Now, the FDA's job is to protect us, the consumer, from marketing of pharmaceutical companies. It is the buffer. And in this case, it failed greatly. The doctor who was responsible for that in the package insert of the drug OxyContin later went to work for Purdue Pharma. So I'll let you draw your own conclusions from that one. So now we've got this drug that's highly addictive, that's long acting, that doctors have been trained by the pharmaceutical industry that they're very low risk of addiction, and they're not doing a good job of treating their patients if they're not using this medication. And they take this medication and they unleash it on a genetically predisposed and traumatized population, mainly starting in Appalachia, but later to the whole part of the country. And then later, when we started to crack down on doctors prescribing this for running pill mills and everything else, we didn't do anything to treat the people who were already addicted, nor to stop the new initiatives. And they simply switched from a drug that they had trouble getting that was expensive on the street and pain pills over to cheap heroin, black tar heroin, powder heroin, and then later something I never saw coming. I saw that heroin coming a mile away. I did not see fentanyl coming. I did not see it. I get people all the time saying, oh, I saw that. And I'm very suspicious those are the same people that saw the stock market crash coming 2 weeks after it happened, because I didn't hear anybody out there talking about fentanyl in 2010. And we're talking about powder fentanyl that's made in China, brought into the United States through Canada and Mexico. And this is not a border talk. I'm not talking about that. That's how it gets here. And then it's adulterated in just about everything. If you're using methamphetamine in the state of New York today, you are going to get fentanyl. If you're using cocaine in the state of New York today, you are going to get fentanyl. If you're a kid and you're swapping marijuana vapes, at some point, you're going to get fentanyl in your marijuana vape. If you're buying pain pills off of the street, and I'll guarantee you the NYPD can back me up on this, you're going to get pills that look just like what comes out of the pharmacy that are fentanyl. Well, what's the difference in that? Oxycodone is 1.5 morphine equivalent. That means that 10 milligram Percocet is 15 morphine equivalents, okay? If you get a hold of what is a 10 milligram Percocet in front of you, oxycodone, and it's carfentanil instead of oxycodone, that's 10,000 morphine equivalents, and you just died. You better hope that the first responder that shows up has Narcan on them, because you got about 6 minutes before you got irreversible brain damage. That's the world we live in now. So I use the slot machine. And guys, if you all have any questions, throw them in the chat box, because I will get to them. So this is addiction. I use those as my predictors, and it is my job to identify those in my patients so that I can give them informed consent about this medication I'm getting ready to write them. All right, so this is my favorite part. I love the brain stuff because I love knowing why I do stuff. All right, and guys, I'm not blaming anything on anything. It's just who I am. So back when I was a young doctor, if we look at my slot machine, in my family history, I've got the Loyds and the Shipleys. And guys, I'm going to promise you this. These are two gene pools that should not have mixed. They should have never mixed, okay? I have 18 first cousins on my family tree line. 14 of us had addiction issues. 4 of us died of drug and alcohol overdoses before the age of 40. My first 7 is on the pay line. Second 7, I grew up with a mom who had untreated bipolar disorder. She also had a benzodiazepine addiction. She was addicted to Valium back in the day. She beat me and my sister. She's a great grandmom, and I've got a good relationship with her today, but she was physically abusive to me and my sister. I have been, and I'm not talking spankings or corrections. I'm talking beatings, belts, belt buckles, baseball bats, tobacco sticks, ends of shotguns and rifles. I think me and my sister would both tell you the worst thing we were ever hit with was the old Aunt Jemima syrup bottles that were about that thick and you could drop from, eye level and not break. And so we were physically abused growing up. When I was between 4 and 5 years old, my favorite uncle started to molest me. When I got a little bit older, it got worse than that until I got big enough to defend myself. So I am a survivor of physical, sexual, and emotional abuse. So when I'm in my last year of residency as a young doctor, I was in my early 30s. And I'd always struggled with drinking, but I had just stopped drinking because I just never could drink it successfully. So I just stopped. I didn't know that predisposed me. I didn't know that my family history predisposed me. I certainly didn't know that my history of physical and sexual abuse predisposed me. I was the first person in my family to ever graduate college. I only graduated college, I graduated med school. And so in my last year of residency, I was on my way home from work one day, and life was weighing on me. I didn't like my wife very much, Karen. By the way, I'm still married to Karen. The problem was not her. It was me, just for your information. My kids weren't very well behaved. I was nervous about getting out of residency and going out into the world. I was sleep deprived because we didn't have work hour restrictions, and I was working 110 hours a week. And so I had all these things on me. I pulled up to a red light in the middle of Johnson City, Tennessee, flipped the glove compartment of my truck open, and there laid some old Norcos. Norco is hydrocodone acetaminophen, Tylenol. You all know them as Vicodin. And so I pulled one of those Vicodin out, got them from a dentist, broke it in half, threw it in my mouth. I lived about 10 minutes away. By the time I got home, suddenly everything's better. My anxiety's better. My depression's better. I like my wife better. My kids are better behaved. That's one hell of a drive home, right? What I didn't know at the time is the area of our brain that interprets pain doesn't separate physical from emotional pain. So I'm dragging this stuff around with me that I've been battling my whole life that's leading to my anxiety, my depression, my sleep disturbance. And all of a sudden, I get a narcotic on board that numbs my area of the brain. And suddenly I think I've found a cure for it all. And that's how this happens so many times. We unleash these powerful narcotics on people that have these trauma histories that they've been dragging around with them forever. And we do it for a legitimate reason, right? We cut them open. We pull teeth, wisdom teeth. That's a common time. And now that area of their brain that's interpreting this pain gets anesthetized and they get relief. And then the broken leg gets better or the teeth get better. But the emotional pain is still there, and they continue to anesthetize it with the opioid. They can't afford the opioid anymore. The doctor cuts them out, cuts them off. They haven't done anything to treat their addiction, and they wind up going to the street and getting hold of counterfeit pills or fentanyl or graduating to heroin. And that's really a very, very common pathway, and it's how I got started. And I went from that 2.5 milligrams of hydrocodone that day to 3 years later, I was using 500 milligrams of OxyContin, which is 100 Vicodin pills per day, and 8 milligrams of Xanax. And guys, I'm not living on the street, and I'm not living underneath the bridge. And I'm going to tell you this, the difference between me as a doctor and that person you see on the sidewalk who's shooting heroin, it's a very fine line. And sometimes it almost doesn't exist. I caught a few breaks. I happened to have an MD degree hanging on the wall. By the time I went through my addiction, I had a way to make a living wage, a 6-figure income. When I went to treatment, I didn't get fired. The president of my university and the dean of my medical school paid me every day I was gone. I never missed a paycheck. You name me people that get to do that. Okay, this changed my life, guys. And what I learned when I went to treatments, there's 2 systems of care in the United States. There's a system of care that if you have money and resources, you have a professional license, like a medical license, a pilot's license, you are a member of the bar as a lawyer, you're an entertainer, you're a professional athlete, you get this treatment. And this treatment, as you progress through it, your progression through that treatment is determined by the clinicians taking care of you. Everybody else gets this. And if you're in this, you have insurance, you have Medicare, you have Medicaid, you have private insurance, it doesn't matter. Your progression through that system is not determined by the people taking care of you. It's determined by the third-party payer that decides when you're better. And guys, I just never was able to look away from that because I got world-class help. If you look at doctors with addiction or airline pilots with addiction, and they come in on day 1, what percentage of them are back in their job, free and clear of all drugs at 5 years? That number is 78 to 95%. What about for Joe American out there on the street that walks into an AA meeting or a 28-day treatment program? What percentage of those folks are free and clear of all drugs and back in their job at 5 years? Guys, it's single digits, 8 to 12%. And it has nothing to do with intelligence. It has everything to do with the system of care that they step into. Why in the world does Steve Loyd work with Chief Tobin and Chauncey and Lisa and Jim? Because we're talking about building that system of care that no matter where you touch this system of care, you get the help that's right for you. And what is the biggest touch point out there in the United States today? Not anywhere close. It's criminal justice. It's local law enforcement. It is our boots on the ground law enforcement and our judiciary system, guys. We will not bend the needle on addressing the opioid and addiction crisis in the United States until we address it in our legal system and our jails and prisons. That is a fact. That is a fact. And that is why I feel so strongly about this. All right. So I've understand to you about the systems of care. You understand the difference and disparity of care. You got to understand the brain stuff because it's the best. All right. So there's 2 areas of our brain I want to talk about. And I know, how many people do we have on here, Lisa? I know you can unmute. How many people do we have on here?
We have about 250 people.
250 people. Good. That I know if I've got 250 people, I got people on here that have got teenagers. We have to. And so those of you with teenagers, I want you to pay particular attention to this part because I'm going to teach you why they're stupid. Okay. Now they're not stupid to make bad decisions, and it relates directly to addiction. So 2 areas of our brain I want to concentrate on. One is where I'm circling right now. That's our limbic system. It's the part of our brain that brings us pleasure. It is all about pleasure, right? Food, water, sex. The other pair, and we're not going to call it the limbic system. We're going to call it go. Everything in front of this vertical fissure right here is the frontal lobe of our brain. We're going to call it stop. Now, I'm making it a whole lot more simple than it is, but I'm going to defend that by telling you if I give you all the structures and their Latin names, we're not going to get anything else done, and nobody's going to know anything, including me. So let's keep it simple. I'm all about that. Go and stop. The go part of our brain is about pleasure, food, water, sex. It has 2 big responsibilities. The first responsibility is it's responsible for our will and our desire to live. Now, I want you to think about that for a second. What would you do to save your own life right now? You'll do anything. If your life was threatened, or if we were all in the room together instead of on this call, we're all in the room together and there's no food or water and we're sitting there looking at each other day after day and nothing around. We're going to do 2 things. The first thing we're going to do is we're going to get desperate enough to drink each other's urine. Guarantee you that's going to happen, 100%. And then we're going to start to eyeball each other to see who's the weakest. And that's the one that's going to get eaten first. That's how strong your will and desire is. That is a go system function. In addiction, what happens is that function, that survival function, is replaced by whatever you're addicted to. So no longer is your goal to live. Your goal is to get this thing out there or you're going to die. What would you do to get the thing that you think you will die without? And the answer again is anything. Guys, I sat outside of a pharmacy in Orange Beach, Alabama in 2003 as a professor of a medical school with my kids playing on the beach across the street with a loaded 45 sitting in my lap, contemplating strong arm robbing a pharmacy. And I am a doctor and a professor of medicine at a medical school in the town I grew up in. I did not wake up one day and say, hey, I think I will become an armed robber. Now, luckily for me, I had what's called a moment of clarity at that desperation point in my life. And I realized in the height of my drug addiction and my withdrawals that I could not recover from an armed robbery. Okay. I was in Orange Beach, Alabama. It was the middle of the summer, and I had a great big University of Tennessee football shirt on. They would have caught me before I got to the parking lot. Okay. And I did not do that. Imagine if I had. Imagine where my life would be right now. When you see a woman putting a needle in her arm and she has a baby in her belly, and you're saying, how in the world can you do that? It's not because she's a bad person. And it's not because she's an immoral piece of crap. It's because she has the disease of addiction, and the part of her brain that is wired for survival has been hijacked by the drug. And now her survival is getting hold of that drug. And when she can get a hold of that drug, now she's going to be okay. I am not condoning any actions here. I'm telling you the reasons for them, because when we understand the reasons for them, now we can address them in a loving way. Guys, every single religious text in the world, if it's a major religious text, has one thing in common. The Quran, I can't pronounce the Hindu text. I'm so sorry. I know it, but I can't pronounce it. The New and Old Testaments of the Bible, right, have one thing in common, and that's loving your neighbor. Guys, that's what I'm talking about right now. I'm talking about loving your neighbor. I'm talking about meeting them where they are and loving them where they are no matter what. There are consequences. Law enforcement has a job to do. They have to enforce the law. There are consequences. But I see more kindness and compassion coming out of my peers in law enforcement than I do in my own profession. That is a fact. And why do I think that is? Because law enforcement's been doing this long enough that they've seen generation after generation come through and realizing what we're doing right now is not currently working, and we got to do something else. And that's why I work with them, and that's why I tip my hat to them. And that's why when I get a call from Lisa, I say yes. That reason right there. And I don't need more of a reason than that. So that's the first thing that our limbic system does. Now, the frontal lobe of our brain kind of acts as the yin and yang to the limbic system. The go system is all about food, water, sex, right? All about survival and our species going forward in time, right? The frontal lobe is about insight and judgment. All right. And these two things work together. So here's how our brain works. Every single day we wake up and we have a series of decisions in front of us. And our brain, our limbic system looks at it, and we pick the system that gives us the most amount of benefit, the most amount of pleasure, the most amount of reward, while our frontal lobe weighs in with consequences. And then we wind up picking the one that gives us the most amount of pleasure and the least amount of consequence, because we have a fully functioning stop and go system. We do it all day long, every day. Right? It's how our brains function. All right. So here's the deal. These two areas of our brain are not neurologically connected until we're 23 years old for a woman and 25 years old for a man. Okay. Now, those of you with teenagers, I just taught you why they're stupid. They're not stupid, right? But they're driven solely by their pleasure center because their frontal lobe is not fully developed. They don't have insight and judgment. And so they don't make decisions in the same way that they're going to make them when they're 30 years old. Does that mean that we don't teach them? Absolutely not. Where do you think they get those decision points in the frontal lobe that they will draw on in the future, right? And if you think I'm lying, think about the first time your kid drove down that driveway without you in the car. How was that? You did exactly what I did, which is lay awake at night with one eye open, listening for that front door to open to know they were safe for another day. They didn't, because they don't understand that they can drive and wreck and kill themselves or hurt somebody else because they don't have that insight and judgment, okay? And if you think, Steve, you've lost your mind, that can't be true. Look at their car insurance rates. When do their car insurance rates go down? 23 and 25. There is a reason for that, guys. That's how our two areas of our brain work together. So those of you who are dealing with teenagers, hang on. They'll turn 23 and 25 and you can start talking to them again. So why is this so important in addiction, guys? Because these connections between this go and stop portion of our brain are arrested in development at time of first drug use. Chief Tobin comes into me, and Chief, I don't know, looking at you, you've been in the NYPD 40 years. Chief is 36 years old, okay? She was a prodigy when she was younger. So she's 36 years old. She comes in to see me. She's shooting heroin. I said, all right, Chief, I'm going to detox you for 10 days, send you out the door, all right? Send you out the door. So she said, you're not going to get sick anymore. You're going to be fine. All right. And so when I send Chief out the door, she's not sick anymore, but she's still going to have cravings. I didn't do anything to treat her underlying disease of addiction. And I didn't understand this slide I just threw up for you. So let's look at this slide. This slide is of a PET scan. Don't get intimidated by PET scans. PET scans just look and see where radio labeled sugar goes. If I had a way to attach a radio label to a sugar molecule where an X-ray machine could see it, and I stuck it in you, all the cells in your body work on sugar one form or another. Those cells are going to light up, and I can see whether or not it's functioning. That's how PET scan works pretty much. That top row of brains that you see here are normal brains. Frontal lobe up top, you see normal brains, uptake through all the brains. Second row of brains are Chief Tobin. Chief comes in, I detox her off the heroin for 10 days. Say, all right, Chief, you're ready to go. Go back out in the world. You're not dope sick anymore. This is Chief Tobin's brain after 10 days of abstinence, and look in the frontal lobe. Nothing. What is present? Her reward system is present. I'm sending Chief Tobin back out in the world with a jacked up, fully functioning reward system with no insight and judgment into consequences of actions. And she thinks she'll die if she doesn't get the thing she's craving. How long does it take Chief Tobin to stick a needle in her arm? In the parking lot of the treatment center, guys. What we're doing is ineffective. Our treatment programs are too short. We don't hold people long enough. Where can we hold people long enough? In the system, law enforcement and criminal justice, we can hold them. We can leverage things against them. And then what I always propose is a system of contingency management where the marks they hit as they progress in their recovery towards that 5 years, there are certain things that we start to forgive, i.e. fines, i.e. other things that are keeping people down when they finally do get into recovery. And I think that there is a way to do that. Now, let's look at 100 days of abstinence. Look what's coming back in that frontal lobe. It's amazing. It takes about 100 days for the frontal lobe to even start to come back online. How long does it take to go from this bottom row of brains to this top row of brains? 2 years. Why do people relapse? Cravings. Why do I love medications like methadone, buprenorphine, and naltrexone? They quell cravings. If I can keep the cravings at bay, I can keep the needle out of somebody's arm, I can give them a chance at long-term recovery. We can go to work on those underlying drivers. That's why I love medication. It's not an end-all be-all, but it is the best tool that we have when people are in the outpatient setting. Second seven stuff. This is one of my favorite doctors in the world, Dr. Vincent Felitti. He's the lead author of the ACEs study, Adverse Childhood Experiences. When your ACEs score gets to a score of 4 or above out of 10, your risk of almost everything goes up. Diabetes, hypertension, chronic disease, cancer, substance use disorder, behavioral disorders. Felitti was a weight loss doctor in the 1980s out in California. He treated morbidly obese women. They would lose this weight. Some of them would put it back on. Others wouldn't. He wanted to know the difference in between the two cohorts. He thought it had something to do with trauma. He came up with a list of 10 questions, but one question in particular got his attention. And that was, how much did you weigh the first time you had sex? And the ages he got, right off the bat, he realized he asked the wrong question because the weights he got were 45, 50, 55 pounds. The question he should have asked was, how old were you the first time that you had sex? These women were victims of sexual abuse in their own family, right? And their drug of choice was food. The thought process was, if I can eat enough, I can make myself physically unattractive to my perpetrator. And I tell that to you to tell you the drug is not the problem. The drug is the solution. That day sitting at the red light in Johnson City, Tennessee, that Vicodin was my solution. I felt better. People tell me all the time, Steve, I don't know why you use drugs. They don't work. I said, you didn't use the right ones. They work, right? They work right up until they stop working. Same thing here. The food made her physically unattractive to her perpetrator. Guys, this is not about the drug. We keep all the time focusing on the drug. Oh, we got to get rid of this. There'll be something else come along. And if you don't believe me, walking any vape shop in New York City, just pick one. I don't care. And this is over the counter. It's mood altering. And there will be 100 more behind those 100 if we outlaw them. And everybody on this call knows I'm telling you the truth. We have to address this from the demand side, right? Or from the demand side for sure. But that does not mean that our interdiction efforts haven't been worthwhile. There have been millions of lives saved by interdiction efforts for law enforcement in the United States. That is a fact. We will not get there on the supply side alone. We have to go to the demand side. One of the hardest places to stay sober in the United States are jails and prisons, right? They just are. And anybody in law enforcement or corrections will tell you that. Why? Because if there's a demand, there will be a supply. You can build a wall from the ground to the moon, and they'll fly over it or they'll dig a tunnel underneath it if there is a demand. And so we have to broaden what we're trying to do, and we have to lessen things on the demand side. We have to be treating these underlying drivers of addiction, which a lot of times are adverse childhood experiences. If you look at people who've experienced trauma, they're 15 times more likely to commit suicide. They're about 3 times more likely to have serious job problems or develop depression. And they're much more likely to use intravenous drugs or develop an alcohol use disorder. We have to address this underlying trauma. How many of the population who are unhoused in New York City have histories that I've described? I bet it's 100%. Maybe we can find one out there, but I bet I'm pretty close. And we're not going to get there with traditional means. We have to look at a comprehensive treatment system that takes into account things that people need to quell their cravings, to address those underlying drivers, and then to start to give them these social determinants of health, which really determine how our lives go forward. And the number one thing there, far and away, is housing. And I really worry about that in the city because I am a huge fan of the city. And I'm a country boy, and I love the city. And when you start thinking about affordable housing within the city, wow, right? We're going to struggle. So these are things that we need to be thinking about as a society long-term and trying to help people who are struggling. And then the third 7, of course, is our social opportunity. This is the study that Purdue Pharma used to market the drug OxyContin back in the day. Right off the bat, you see it's not a study. It's a letter to the editor of the 1980 New England Journal of Medicine. And it's not a study. They had 40,000 people in the hospital. About 12,000 of them got a pain pill while we were there. Only 2 of them became addicted when they left. That is not a double-blind placebo-controlled study, and it's not even comparing apples to apples because hospital stays are short and outpatient treatment of chronic pain is long. And when you see big industry losing lawsuits over this, this is one of the major reasons why. So I've covered all 3 areas of the slot machine, and I'm going to tell you all this. We've got 200 plus people on this call. I have no idea how many doctors we have on this call. Don't care. I will tell you this. All of you right now, in less than an hour, know more about addiction than 95% of the doctors living in your communities. And I don't care if you live next door to NYU's medical school. Okay. You know more about addiction than 95% of doctors in our community. And I think that's a shame. So let's get into why this matters and why I love the HIDA concept, right? We have to talk about a recovery-oriented system of care. The young lady you see in front of you is the toughest patient that I ever had. Her name is Brooke. She's 25 years old when this picture is made. She's living in Ohio. She's using IV fentanyl and IV heroin and one other drug. What's the other drug? That's easy, right? It's methamphetamine. When you see marks like this on patients, these pick marks along the top of her chest, neck, chin, around her lips, up top, methamphetamine's made out of stuff you get at Home Depot and Lowe's. It has impurities in it, gets deposited under your skin. You pick at it. This is what you look like. Brooke is 25, and she figures out she's 8 weeks pregnant with her first child. And she doesn't want to be like that, and she wants it to have a better chance than she had. Let's look at Brooke's SWAT machine. First 7, long family history of addiction. Second 7, a childhood trauma that my Sunday school class don't want to know about. All Brooke was waiting on was the social opportunity, which came in the form of pain pills when she was in middle school. And then she later graduated to heroin and fentanyl, the exact same path I taught you guys earlier. So she goes to her mom. They Google doctors who will take women who are pregnant and drug addicted. My name pops up. I'm easy to find. My phone number's on the internet. They call me. I met Brooke 7 hours after this picture was taken. Brooke is the toughest patient that I ever had. I knew her for 2 weeks before she called me anything other than MFer, and she wasn't using the initials, guys. She was going to see if I was going to run, and I don't run. I've been called way worse than that. And I love Brooke. She became my friend as well. And I don't care if I've got people say that shouldn't happen. It does. And I cared deeply about her. Good thing about pregnant women is you can scare the heck out of insurance companies with them. And I did. And I got to keep her a long time. This is Brooke on her 26th birthday. She is 38 weeks pregnant. Pregnancy's 40 weeks. And she looks great. We've got her in sober living. She's getting help with her underlying behavioral health issues. She's getting help with her childhood trauma. She is on 1 Subutex today and doing wonderfully. But this day is bittersweet because she turned 26. What happens when you turn 26? Lose mom and dad's insurance. So she goes on Ohio Medicaid. And she wants to go back to Ohio to have her baby because there's something back home called a baby daddy. Guys, I had no idea what a baby daddy was. That wasn't my world. My kids had to tell me about looking things up on Urban Dictionary. That's how I figured out what a baby daddy was. Brooke wanted to go back to the baby daddy, but that wasn't why I was upset. Brooke is going back with Medicaid to a rural area in Ohio, and there aren't any doctors who accept her Medicaid, and I'm her doctor. And I'm not the best doctor in the world. I am average at best, but I care deeply about this population, and I take Medicaid, and I take Medicare, and I take private insurance. And if you don't have any money, I've secured grant money, and I'm going to treat you for free. Brooke didn't have that. She also has 2 felonies, and her felonies are possession with intent to resell, and Brooke was not a dope dealer. Her tolerance for heroin and fentanyl got so high that the amount she had on her was enough to trip the scales in between a misdemeanor and a felony, and she's got 2 felonies. Try getting a job as a certified welder with 2 felonies. Good luck. She could only get a job making minimum wage, and the doctor she was going to see is only going to take cash. And so she's taking all the money she makes in a minimum wage job and paying a doctor just to write her a medication and do nothing for her underlying trauma. That's the system of care that Brooke stepped into. My favorite picture of Brooke, not long after delivery, that's her daughter, Ava. I want you to look at Brooke in that picture. Brooke is a dime. Y'all know what a dime is? That's a 10. Brooke is a damn 10, right? That picture to that picture is 32 weeks. You want to know why I love my job? I get a front row seat to the miracle. I get to watch this all the time. But Brooke is struggling. She's living with her mom, making minimum wage, paying the doctor all the money she's making, not getting help with the things that are really bothering her. And she wound up relapsing and get thrown in jail. And when she got thrown in jail, a rural sheriff who has no medical training, no business delivering medical care, stops all of her medication because he says she doesn't need it. Let's leave Brooke right there. You recognize the guy on the right there? That's me. I've already showed you this. I get jealous every time I see this picture because I love that head of hair and I miss it. This is me on the last day of medical school. I didn't drink or use anything in medical school because I was a turtle on a fence post. My classmates elected me their class president all 4 years. I could not embarrass them by being drunk in public. Only this day happened, and we spread to the 4 corners of the earth. And in 4 weeks, I was drinking In less than a year, I was using pills. My turtle on a fence post disintegrated around me. This is me and my little family. I was at the height of my addiction. We're headed down to Knoxville. I'm a huge football fan. That's my son Heath, my daughter Haley, my wife Karen, and me. I love that picture and I hate that picture. A young doctor with my whole life in front of me. But if you look closely, there's a bulge in the front of the pocket of those khakis. And those aren't my keys, and that's not my wallet. That's a bottle of pills. You can pick addiction out of that picture. Can you pick it out of that one? Probably not. Guys, this disease knows no boundaries. It's not blue or red. It's not Democrat or Republican. It's not city or country. All right. It is the same. The same underlying drivers are there. Some of the social factors are a little different, but we have to address them individualized based on that patient. I love kids, always have, always will. So this is Disney World. My two kids are in this picture, my niece and nephew in this picture, my two goddaughters are in this picture. When we go to the beach, all the parents are under the umbrellas drinking. I'm in the water with the kids, and now I'm in the water with their kids. And I love that about me. And I love this picture. And it's been a while since I've seen this particular one. Didn't know I had this one in here. Also hate this picture because I'm shiny in this picture. I look great, right? Except for underneath it, I'm dope sick. No matter how important those kids were to me, guys, the most important thing was having that drug that I needed or I thought I was going to die. It goes back to the brain stuff I taught you early on. I got world-class help. I stepped into a system of care that was designed to put me here today. I told you my titles, not to brag. I'm still in awe of them. I can't believe they're mine. I told you those to show you what's possible when we give somebody a chance in a system of care that allows them to build a life. A few years ago, I got a registered letter in the mail and nothing ever good comes in a registered letter. You all know that. Only this one did. Our governor, Governor Bill Lee, appointed Stephen Loyd to the Tennessee Board of Medical Examiners. Right there I sit with my colleagues. I am now the president of the Tennessee Board of Medical Examiners. And guys, I should be in front of the Tennessee Board of Medical Examiners. I'm a turtle on a fence post. I am where I am because I stepped into a system of care that put me here and supported me and continues to support me 21 years deep into my recovery. Brooke stepped into a system of care that didn't do those things. She stepped into a system of care that threw her in jail, took her medications without seeing qualified doctors. And on the morning of December 13th, 2020, I got a phone call early in the morning. It was a Sunday from Brooke's mom, Angie. She said, Steve, I found Brooke cold and blue in her bed this morning. Brooke died of an acute overdose of heroin and fentanyl. She is one of the 107-622. You now know one. And it was totally preventable. There are people out there that say we can kill our way out of this. I've seen politicians say that. Let enough of these people die, by gosh, we'll get out of it. Darwin, right? There's one huge problem with that, guys. And it's that right there. Who is that? That is Miss Ava. She is 2 years old when this picture is taken. She's now 5. She's potty training. She appears to be very pleased with whatever's happened right here, right? She will never know her mother. Her dad is incarcerated. We already know her family history. Her first 7 is on the pay line. Mom and dad both with addiction. Let's look at her second 7. She's only 2 years old. Her ACEs score is already 2. Mom is dead. Dad's in prison. If we don't intervene on this child, what are the chances in the next 10 years this child is in our system? ACEs score 4 or above, everything goes straight up. Her ACEs score is already 2, and she hadn't had control over any of that. Guys, we can't kill our way out of this because of the trauma that's left behind and the families that are left behind and the level of devastation to those families. We have to change our approach. We have to intervene on these at-risk kids early, and it needs to start in elementary school. And people say, well, we start talking to them in high school. Guys, high school, the horse has left the barn, okay? You're closing the barn door after the horse is already gone. We have to intervene early. What do I propose? A recovery ecosystem. I was a leadoff expert witness in the cases that brought the opiate abatement money to our states, New York State included, and we won about $55 billion. How we spend that money over the next 2 to 5 years will determine the system of care that we have for the next 20 to 30 years. And I propose this system This is the people who are our referral sources. Number one referral source in the United States for opioid use disorder or any other substance use is our criminal justice system. Our first responders, our law and our judicial system. Doctors aren't even on the list. This is what happens in treatment. This is what we're after. Somebody who's happy, healthy with social support, housing, transportation, and employment, contributing to the tax base. I tell people all the time, I deal in strings, 2 strings, heartstrings and purse strings. If I can't get you with the heartstrings, I'm going to get you with the purse strings. We should be doing this because we should be loving our neighbor. It's the right thing to do. And I'm telling you this is still a great country, and we still care about each other. The greatest asset the great state of West Virginia has in battling the opioid addiction are their sense of community. It will be what turns the tide. When I come to New York and I sit in on team meetings, I see a sense of community among people you wouldn't think. Hardcore law enforcement, cops, right? And I see this sense of community and working together to help people find a pathway to stop the repeated cycles that they're in. Guys, what I'm telling you is this system, this dog will hunt, and it's been proven. So first off, we've got to have pre-treatment. I call them survival programs, widespread distribution of overdose reversal drugs, syringe service programs, and overdose prevention programs prevent people from dying to prevent the spread of hepatitis C and HIV. And if we're going to prevent babies from being born drug exposed, we had better increase opportunities for young women of childbearing age to get voluntary reversible long-acting contraception. We have to have increased access to medications to treat opioid use disorder and support systems for women who are pregnant or postpartum and for children who have been exposed to drugs intrauterine prior to birth. We absolutely have to have treatment programs in our jails and prisons in every state in the United States. And we have to get really good at warm handoffs from the carceral setting into the community because, guys, here's the deal. 95 to 97% of incarcerated individuals in the United States will walk the street again. And we need to make sure that they're walking the street as healthy as possible. And we're not going to do that as long as we deny them care for their substance use disorder while they are incarcerated. Housing. If you give Steve Loyd a pixie dust and say, Steve, we're going to give you one thing. You get this unconditionally. Guys, it's not going to be medication. It's not going to be treatment beds. It's not going to be all the things we think about. It's going to be housing. All of us on this call and on my screen, I've got Chief, I've got Jim, I've got Lisa, and I've got Megan. And all of them look really good, and I bet they smell good. Okay? I can't smell them, but I bet they do. How would they look or smell if they slept on the street last night? What would it be job interview-wise to show up and not have a place to take a bath and brush your teeth? All right? Guys, we have to get serious about housing. And we have to look at what the drivers are, and we have to get rid of some of the political things that are preventing us from getting people stable housing. We've got to enrich our treatment programs and evidence-based treatment programs, and they need to start in kindergarten and first grade in our schools. We've got to get really serious about data collection and continuous quality improvement. The day I got to spend with Chief and Chauncey and the officers of the NYPD, I was blown away about how they use data. It's incredible. I mean, to me, the city is this place that I can't even comprehend. And these dudes and dudettes who work at this place, they know every street. They know about every person on every street. They know where the crime is happening. They know where the gun crime is happening. They can almost predict when events happen in our world where this is going to happen. It is amazing at their utilization of data and their willingness to share that data with other parts of this system around them. I was blown away with that. We've got to copy it. And last but not least, guys, this money is absolutely, I'm not sure. Lisa, y'all still there?
Yes.
This money has to be transparent. We need to know who it's going to. We need to know what it's for. We need to know what the expected outcome is. And we absolutely have to involve people with lived experience. We will not get out of this not involving people who have lived through it themselves in our certified peer recovery programs. They are crucial to us finding a solution. Guys, I'm more than my ACEs score. I told you about my childhood trauma, the physical and sexual abuse. I'm not upset about it. I'm not mad about it. It is what happened. I got world-class care. I got help in building resiliency. I am not my ACEs score. I am Stephen Loyd, husband, father, dad, granddad, doctor, towards the end. And I am a turtle on a fence post. As a little boy growing up in Jonesboro, Tennessee, I never dreamed I'd take my family to Italy, but a few years ago I did. That's Florence, Italy in the background. I hope I get to see it one more time before I die. That's my son, Heath, my daughter-in-law, Laura, my wife, Karen, me. I want to talk about this thing right here. This is my daughter, Haley. And before you all start getting on me, I'm a firm believer in the old double standard. I love my son. I love Heath. He's my best friend. When it was time for him to go to college, his ass needed to go. It was time for him to launch, and I love him. My daughter, completely opposite. I told Haley, if you will live in your bed until you die in your bedroom, I will pay for everything. You won't have to worry about a thing as long as you stay under my roof. And you all know how well that went over. One day when she was a junior in high school, she brought that thing home. His name is Sterling. I met him on the front porch their first date. She's a junior, he's a senior. The car he drove, no way in hell my daughter's getting in. I gave the kid my car that night because I at least wanted to make sure she had stable wheels underneath her. I met Sterling. I talked to him for about 5 minutes. I went in and told Karen, my wife, honey, I think I met our son-in-law. She said, come on, Steve. It's our first date. They're in high school. 6 years later, I was standing in Charleston, South Carolina at the end of an aisle. The other end of that aisle had a preacher. And guys, if there's any men on this call, let me tell you, if you've got daughters, don't worry about college. You can pull that out of your bank account. You had best be saving for them getting married. You ain't pulling that out of your bank account. And so it cost a fortune, and I'm a mess. I'm crying. I've got tears everywhere. I'm getting ready to walk her down the aisle. She's on my right arm, and she leans her head over, and she says, hey, Daddy, she said, you're the first man I ever loved. Thank you for everything you ever did for me. That's the deal. That's what we're after. That moment right there. Now, my kids don't know I use these pictures, and that they don't know I use these stories. But in that program that we handed our guests that night, I'm Stephen Loyd, father of the bride, May 11th, 1967 dash. Guys, I'm a dash. I'm a dash because I'm turtle on a fence post. I got to walk my daughter down the aisle that night when she got married because I was present in her life and I did not die in 2004. Somebody else didn't walk my daughter down the aisle. I did. My son got married during the pandemic year in October. In April, everybody's living with me in my house because they hadn't bought their houses yet. We're having dinner at the family dinner table. COVID did bring back the family dinner table, and I'm grateful for that. No sports on TV, and we're talking. Heath comes down. He played college baseball. He's got 100 buddies. He sits down and he said, hey, Pops. He said, would you be the best man at my wedding? The two most important days of my life, guys, are the day I stood beside my son and the day I gave my daughter away. And I was there because I was a turtle on a fence post. Everybody's story won't be mine. They won't be fortunate enough to do. They'll do bigger things. We got to give them that opportunity. We got to give them that opportunity by building a system of care that is specific to them. Too many times in the treatment world, the treatment you get is dependent upon where you go, and you get the treatment that they happen to provide. And we got to get past that. We've got to work closely with our colleagues and peers in law enforcement to be able to leverage what we have in law enforcement to help people find the path to recovery that's right for them. And we have to get rid of some of our turf protections of some of our data so that we can better figure out the pathways that is for most people. And I'm going to close with the next slide. This used to be my last slide because it was my favorite slide. Now, I'm going to tell you all that I love my son and daughter, and I love my wife, and they're wonderful, right? They do not match this. So when I leave here in a few minutes, I'm going to get in my car and I'm going to drive 5 hours west because at my home in Nashville right now is my granddaughter, Cece. Cece is about 2 years old. She's a little over 2. She loves her bath, and she loves it when her granddaddy gives her a mohawk. And this is my favorite picture in the world, and I get to do this tonight because I'm a turtle on a fence post. I didn't do this by myself. I have a system of care around me and colleagues around me and peers around me, and this group is a part of that. I get to work with members of the NYPD. I get to work with Lisa. I get to work with Jim. I get to work with Chauncey, who was the vice mayor of our city. These are the people I get to work with. Look at my gifts in recovery. Guys, this is the goal. I don't get sidetracked by politics. God knows I could. I keep my focus on hurting families, and I'm not going to change that in any way. And so I'll leave you with this. Addiction's treatable. Treatment works and people recover. So let's change our attitudes and open our minds to that system of care. Thank you, guys.
Thank you. Well,
Bravo.
bravo. Yeah.
I know you can't see everyone's responses or what's in the chat, Dr. Loyd, but if you could see what our screens are lighting up with red hearts and applause and just clapping and just pure love for your presentation. So
Yeah. I apologize. We just did not want to stop and you guys from hearing all the precious words from Dr. Loyd. So there's some questions in the chat. We will follow up. We'll connect with Dr. Loyd and we'll send out the answers and responses to all those questions. But we don't want to keep you beyond the time frame. But yeah, Dr. Loyd, we can't thank you enough. And to all the people that showed up today, thank you so much for your participation, your feedback, and we are so glad you continue to engage with these sessions. You remind us of why this is so important. So thank you so much. And Jim, if you have anything or Chief, anything else to say before we wrap up. But we have all your information and we're going to follow up.
And Lisa, I promise you, I'll answer every one of them. If you all send me a question, give me a tad bit of time because there's a lot of you on here. And I told Lisa one time I had over 100 questions that I answered, but I do get to them. I promise you. I just may need a little time. But thank you guys so much, Chief. Great to see you.
safe travels. Enjoy that CC. She's gorgeous. Have a blessed holiday season, everyone. And we will be in touch for sure. Thank you.